Handed out scoliosis check sheets, okay? First thing people think is like, oh, I don't have little kids. 35% of the population over the age of 65 has degenerative scoliosis. And there's really only one way to treat the scoliosis, aside from physical therapy, which is helpful. And that's through scaffolding. Now, scaffolding can either be inside or it can be outside. So this is a Scoli brace. It's a 3D overcorrection brace. It's made from a company called ScoliCare out of Australia, which is owned by Dr. Jed McAvee, who is the inventor of the Scoli brace. He happens to be an advanced certified chiropractic biophysics practitioner, just like myself, but smarter. And one of my instructors. I've been training with them for about 7 years. So unfortunately, there are not a whole lot of practitioners that do what I do, and I really wish there were more. And I'm out of the 921 chiropractors in Maryland, I'm the only one that does this. And in DC and Virginia as well, unfortunately for adults, okay? I do some kids too, but mostly teens or late teens. I'm not a pediatrician. Like I'm not wired that way. At 30 years in, I just can't. In fact, the reason why I became a chiropractor is because I don't like blood, guts, or naked people. So I will file little kids or tears with stuff leaking out of their eyes when I put on these braces in the blood, guts, and naked people, because it's just heavy. It's heavy. I want to help people. I want to help the consumer, really. I just don't have the patience for the kids at this stage of my career. But I'm very plugged in, and I can help every kid that comes to the door indirectly, even if I don't accept it myself. Just wanted you to know that. Born in DC in 1970, raised in Silver Spring, John F. Kennedy High School, 1988, go Cavaliers. 1992, graduated University of Maryland. I have a psych degree from there. I don't know anything about psychology except for what I've learned treating patients over the last 30 years. I love Maryland. I'm a Terp. You cut me, I bleed terrapin red. Absolutely. I'm here because I left Georgia when I got my doctorate to come home because at the time my grandparents were living at Leisure World. My parents were here at the corner of Wilson and Bradley, right? And so I just wanted to be home. Maryland was my home. And over that time, I was sort of a traditional chiropractor, but I had started studying what was called chiropractic biophysics, but it was a new type of practice. It's a structural rehabilitation, if you will, okay? So who's been to chiropractors here before in the past? Anyone? Okay, headaches, neck pain, back pain, that kind of thing? Hopefully, I'm not even gonna ask you, hopefully it was a positive experience. Not all 70,000 of us practice the same, so maybe it wasn't, okay? We can go down that and I can compare it to medical and PT and all that, but that's not the point. The point is, I don't really do that, okay? I can do spinal manipulation. It is part of what I do, but it isn't the treatment in itself. So in other words, scoliosis is not treated through spinal manipulation. Can it be beneficial for pain? Absolutely. Can it be beneficial with mobility? Yes. Can it help overall function of the body? Well, I am a chiropractor, so I believe that we heal from above down and from inside out, from the brain, down the spinal cord, out to our organs and cells and tissues that keeps us vitally healthy. That's our philosophy. So in chiropractic is an art, science, and philosophy. The art of practice is how I decide to practice. And if you come to my clinic, you'll look around and be like, this is different. Well, that's my expression of the art of practice. The science and philosophy, the science is just anatomy and physiology. But the philosophy is that if we keep our nervous system free of subluxations or misalignments in the spine, it'll keep the pathway open, thus allowing our body to function normally. That's basic chiropractic philosophy. And that doesn't change for me. What does change is that I don't chase pain directly. So if somebody has headaches, neck pain, or back pain, just straight away, they generally don't find me. They usually find me when regular spinal manipulation, regular physical therapy, massage therapy, other forms of acupuncture, even injections and other things haven't been able to get them where they need to be because unfortunately, the underlying distortion in posture has not been addressed. So the changes are not longer lasting and the pain becomes a chronic pain syndrome that happens over and over and over. So if there's a distortion in posture, if we're out of alignment, that means that there has to be a normal. So in chiropractic biophysics, we have the Harrison spinal model, which was developed in the 80s by Dr. Don Harrison, who was a chiropractor and had a PhD in physics. His son, Dr. Deed Harrison, who's about my age, now he has a master's in engineering. So he's brilliant and happens to be the most published chiropractor in the history of our profession. I've already sent Tiffany an email that has at least has three websites that I'd really like you all to read up on. ScoliCare protocols, which we're going to discuss, Chiropractic BioPhysics, which is the basis of ScoliCare. ScoliCare would not exist if Chiropractic BioPhysics hadn't come first. And then the last one is on the SOSORT guidelines from 2016. SOSORT stands for the International Society of Orthopedic Scoliosis Rehabilitative Therapeutics. Rolls right off the tongue. All right, so I'm a member. I'm very proud of this. I just got back from Turin, Italy a few weeks ago, where I became an official member by joining their Congress. So it means I can do research, I can review, I'm a member. So SOSORT's only purpose is non-surgical management of scoliosis in whatever way that looks. But the research is incredible. Like, I was blown away by what I learned there, and just by some of the even researchers from China and other places that don't sort of have the restrictions that we have using animals and stuff. It was incredibly fascinating. Also made me realize that I'm really not in it to win it for the little kids the way these other practitioners are. So I'm sticking with adult. Okay. But a lot of kids can be treated like adults because they're missed, unfortunately, early on. So in chiropractic biophysics, our ideal normal from the front, spine is midline, obviously, right? From the side, there's a curve in the neck, curve in the mid-back, curve in the low back. In the ideal normal, in 2/3 of the population, that is a negative 42-degree curve in the mid-back, a 44-degree curve in the negative 40-degree curve in the neck, 40-degree curve in the mid-back, and a negative 40-degree curve in the low back. The other third of the population, we could determine what the normal curves are by doing measurements in the pelvis on X-ray. So in other words, I can't do my technique without X-ray. And so I have X-ray, I have digital X-ray. And if someone wants to be my patient and they say, you can't take X-rays, I say, you can't be my patient. Sorry, I'm sorry, you're pregnant. We have to wait until you're not pregnant. You know, so, and also doing posture correction on a pregnant woman is just not smart. But anyways, so ideal normal. Chiropractic biophysics is exercise, it's adjustments, and it's traction. All three of those are done in the mirror image of the distortion that we measure on X-ray. Let me give you an example. So it's a little neck, but let's give it a nice kyphosis here, right? Like, not only is the head forward, but the curve is reversed. So the mirror image to that wouldn't just be bringing the head straight back and doing these chin tucks. It's just not complete. You have to fulcrum the neck and extend over the kyphosis to mirror image it. So it sounds simple, but a lot of people miss that. And so all they're doing is manipulating the spine over and over again and unlocking it, but they're not addressing the underlying distortion. Our head is 15 to 20 pounds, depends how smart you are, I guess. And you take that, you put it forward, you take this and you take it the other way. The weight of the head is now wearing down on your spine whenever you're weight bearing, slowly over time. And wear and tear is real. Unusually, it's different, kind of different from person to person. Some people are a little bit more hardy, and it seems like they can have distortions of posture and the spine doesn't sort of melt on itself over decades. Other people, it's like candle wax. You're like, whoa, when you look at it. And there has to be a semblance of normal anatomy in order to see a change on X-ray. So I'll say that again. If the segments of your spine have started to change shape due to degenerative arthritic changes and the weight bearing, especially for carrying excess weight and doing repetitive stress, our spine will start to change in a way and then become rigid, where these kind of improvements are just no longer possible. Everyone's different, but I measure that. I measure the rigidity. So it's not like I say, all right, we'll come in 3 times a week for 12 weeks, reshoot the X-rays, measure the changes. Looks like it didn't work for you. Sorry, thanks for the money. No, you have to make sure that the appropriate treatment for the appropriate condition for the appropriate patient, because the only thing that really matters here is outcomes. And to me, yeah, if they're feeling better, great, that's great. I want to see a change. I joke that I ruin people for posture. I do. You can never look at your posture again the same way after I'm done X-raying you, do the posture analysis and show it to you and review it with you. It's impossible. I tell people I'm a chiropractor, people already do, oh, really? Like, I get that already, right? But when you're a posture doc, you see the worst of the worst. I really enjoy treating collapsing deformities of the spine. I know that sounds terrible. It sounds funny to say it out loud. because I'm able to help people in a non-surgical way that most people have no idea about. So this may look a little bit like torture, and maybe it is. Okay, this one's fully lined though. This one is a hard polyethylene, so we're gonna get the maximum amount of correction out of this. But an adult only needs to wear this 2 to 4 hours a day in order to very easily stop the progression, decrease the pain, and sometimes even make some measurable correction on X-ray. Maybe not necessarily on what we call the Cobb angle, but patients fall into distortions over time. They start to collapse. They become weaker over time. I have a study right here that shows that even wearing one of these can actually make you stronger, because the biggest criticism we've had over years is that, well, bracing makes people weak. It's not true, okay? Sometimes if it's a really bad brace and you're just being very sedentary and you're not doing what you need to do, yeah, but not this kind of brace. It can actually help increase your core strength because you are more upright, you're more centered over mass, and you're more mobile, you're moving more. And I get patients that only wear this on their daily walk in the morning and maybe a couple hours in the evening, and it's enough to break the cycle of pain and it actually improve their posture out of the brace in about 90 days. So I always ask, Dr. Jeb, the CEO of ScoliCare, I ask him directly, some challenging questions, because I get challenging questions from my patients. And one of the challenging questions I get is, oh, do I need it for the rest of my life? And I'm a direct guy. I say, yes. Yeah. He says, well, you'll benefit from it for as long as you use it. I just don't like that. If you want an orthosis, it doesn't have to be hard polyethylene. And in fact, sometimes they can't tolerate it, even if I fully line it. So there is a softer polyethylene that actually helps to support as well. This is a Scoli brace. There's also a kypho brace, and there's also something called an anterior sagittal brace. And there are other various types of braces that are hybrids of those, that it doesn't necessarily have a paddle here. It might have two, it might have arms. So there are various different types. So I have to decide with ScoliCare as to what is the perfect brace for that particular individual. And the way we do that, I forgot my iPad, but it's okay. I have an iPad with a scanner on it. So not only do I x-ray, and then I x-ray full spine, I do 9 x-rays to start, 4 of the neck, 2 of the mid, 3 of the low. If let's say you have an S curve, so the most common scoliosis is a left lumbar and a right thoracic. Okay, so I have 2 curves I have to address in this patient. So on that patient, I'm going to do side bending x-rays here and here. I'm going to do side bending x-rays here and there, and then measure the rigidity. All of that goes into the iPad. I take photos, sports bra and bike shorts, a lot of skin, right? Got to see it all. I do 6 photos and 4 scans. So it's a 3D scanner that actually paints the individual. So the brace only fits the person that it's made for. That's it. And it takes about 3 or 4 weeks to get the braces. I x-ray the patients day 1 in the brace, just for the ideal fit. And you can see changes in their spine on day 1. And sometimes I had a patient that came in yesterday morning. I took her down from, she had a left thoracic lumbar. So it was just 1 curve, but it's 31 degrees, which is moderate. And it took her down to 9 degrees when I put her on the brace on day 1. Granted, I put it on until she was blue in the face, but I did. It shows you what it's possible, okay? There is a weaning in process of this, okay? So it takes patience and it takes work. This isn't just, I don't hand these out like candy. These are custom made to the individual, but it is life-saving for some people. I have people in their 90s and 80s that are walking around. They're living a great life. I have one patient, she's not quite 80 years old, but she's had neurosurgery like 4 or 5 times. And one of them was a full fusion. I'm not going to tell you the name of the surgeon, but he's very reputable, and I actually refer to him. So I don't blame him, but it broke. The metal inside of her broke. So she had to remove it. He had to remove it. And so not only did she have the surgery, she had the surgery to have all the hardware from like her mid back to her low back removed, and she still has fusions in her neck. So she's a trooper. I see her as a new patient. I walk into my consult room. She's sitting there with a biohazard bag, and she's like, jing, jing, jing. Can you help me not have my surgeon put this back in my spine? I was just, again, I'm not a blood, guts, and naked people kind of guy. So this is like heavy, so this person's asking me, can I help them avoid another surgery? So it's important stuff, you know, and to this day, I'm happy to report she has not had surgery again, and she's doing well in her brace. But I had to do a very specific type of brace for her. Let me back up for a second. Who knows what scoliosis is? All right, someone give me a definition. Yes, that's part of it, absolutely. Rotation is also part of it, okay? The technical definition of a scoliosis is a deviation of the spine with rotation, and the curve has to be 10 degrees or greater. If it's 8 degrees, you don't have a scoliosis. You have a deviation with rotation in a curve of 8 degrees, technically, okay? So below 25, technically is mild. 40 to 25 is moderate. Above 40 to 60 is severe. Above 60 is extreme. Anything above 60 is generally a surgical candidate. If someone's in their 50 degrees, we generally send for a neurosurgical or spinal, orthopedic spinal specialist consult. Doesn't mean we want them to do that, but just so they understand what the options are and what's possible. Bone density plays a part of this. Who goes for their DEXA scan? Every 3 years? Arms came right down. Ever since the pandemic, it seems like people are going less for their DEXA scans. And just because you're not a white person, I would still do it. I'm seeing it across all races, okay? And the reason why I say that is because white Eastern European women are the one that get osteoporosis the most, but I'm seeing it across Asians, African American. I see it a lot, and I catch it. And when I ask my patients, oh, when was the last time you had DEXA? What's that? Oh, when was the last time you had a physical? Gosh, you know, I haven't been in a... I'm astounded. It seems like ever since the pandemic, people don't go for primary care anymore. Who hasn't had a physical? No, I'm not gonna do that. All right, but it's like it's crazy. I go every year, and even not that I necessarily listen to their recommendations, but at least I get my blood chemistry checked. It's just such a low bar of self-care. So I would encourage you all to do that. Vitamin D level is also another really important thing. So understanding your DEXA scan and understanding your vitamin D level, that needs to be managed with your medical doctor, okay, or nurse practitioner, whoever your allied healthcare provider that's doing your primary care. And it matters. It matters for bracing to a certain degree. I can still brace people with osteoporosis, but if it's very severe, you know, we have to really be careful. There's certain distortions that are just out of the range. It's just too much. All right, let me back up for a second. I didn't mean to really go down the scoliosis rabbit hole because it's something I'm the most passionate about. And it's the thing of it, it's so much fun helping people in a way that they didn't even know was possible. And especially when they've given up hope. Because if any of y'all have lived with these chronic degenerative conditions and a pain syndrome that does not seem to go away and you're being handed off from practitioner to practitioner to practitioner, it's demoralizing, to say the least, okay? One of the things I make sure that I always make sure that my patients understand is that I'm very much a least invasive things first kind of guy, graduating to more invasive things as needed, okay? Pain sucks, but most of the time it can be managed, all right? It can be managed in such a way that it's an adequate quality of life and you can perform all your activities of daily living. That's gonna vary from person to person. But going to the end of the line, going to that last house on the block and going straight for surgery, I just want to get this stuff taken care of, that never resonates with me. And I've seen so many people go from the frying pan into the fire with that. Sometimes people need it, but I would say that need for surgery should be driven by objective measurements like NCV EMG. Does anybody know what that is? Nerve conduction velocity and electromyographs done by board-certified neurologists. It tests the speed of the nerve coming off the cord to the tip of the fingers or the tip of the toes, which is important, knowing the speed of the nerves, because we don't want that to be slowed. Also, the contractibility of your muscles. Has anyone here ever experienced weakness before? It's scary. So weakness could be secondary to pain, or like, I just can't get that strength, or it could be an actual degenerative condition that's advancing over time. So if you don't catch it soon enough, it can become permanent. That's why I don't mess around. I send to NCV EMG, and generally speaking, anytime someone has a serious disc injury and I notice any sort of changes in their reflexes or in their strength, they can't do the heel toe walk, you know, they can't do that, or they complain that their legs are giving out or they're dropping things. It's one of the first things I do because I don't want somebody progressing on my watch. Then I just ignored something. I ignored a sign that it should not be ignored. So loss of function is never acceptable. So when we're talking about that, then we're talking, generally speaking, about more serious interventions if someone isn't responding quickly. Because again, tick tock, we don't want someone to get weaker and weaker. And I take that charge seriously. And so I play well in the sandbox with other providers, and in particularly pain management physicians. I have a ton of friends, and they're my friends now after all these years, but interventional spinal pain management, which is generally an anesthesiologist or a physiatrist. Has anybody heard of a physiatrist? It's a medical doctor that's board certified in physical medicine and rehabilitation. Sort of like a PT with an MD that can also, and if they do a full year fellowship, they also do the video floor injections prior to epidurals, facet blocks, nerves block, radiofrequency ablation, spinal cord stem implants, stuff like that. And regenerative medicine techniques, PRP, stem cell, and that kind of stuff. But least invasive, we want to see if our body can heal itself first. And the best way to do that is making sure the body is in alignment and making sure the body is strong and functioning. So chiropractic biophysics, which all of this started with exercise, adjustment, and traction, all three done in the mirror image of the distortion. This is a home neck orthosis, neck traction unit. It's called a Denoroll, developed by Dr. Adrian Denawal from New Zealand. And he named it after himself. So this little device here, in some people, can restore the curve in their neck if they do it every day at home for more than 7 minutes. The way that works is sort of a biohack. We are isolating the spinal ligaments to heat them up, to retard them to hold a new position. I could put this on some people and they would be miserable, okay? So it's not for everybody. That's why we x-ray. And not just neutral x-rays. I x-ray flexion, I also x-ray extension, so I can see how the spine is moving. So you want to be able to do the right thing for the patient. You know, my first job truly is not to hurt my patients. I guess that's obvious. My second job is to help them if I can. So this is an example of, for the neck. This one, can you imagine laying on this on your back in between your shoulder blades and having your head extend all the way back with this little, it's pretty dense too. This is a thoracic Denoroll, so for home use. This is a lumbar Denoroll. So let's say I have, just as an example, a 40-year-old male who's come in and his back pain will not go away. Okay, he goes to chiropractors, he gets adjusted, feels better for a few days. He goes for massage, he unlocks him, but his back is seizing up on him 2-3 times a year. Every so often he gets pain going down his legs. He's had MRIs, maybe even had an epidural or two because there's a bulge here and there, and the doctors are chasing that. I take an x-ray of the patient from the front. It looks pretty midline, but I take an x-ray from the side, and I see his thorax has gone backwards, and this curve is collapsed. So anyone with a 30% reduction in curve of their low back, looking at from the side here, that sloucher, they have pain. I don't even have to ask them. I know. So one of the first things we start with gentle manipulation, gentle stretches, but we start pulling the curve into their back 3 days a week for a couple of weeks. If the frequency, duration, and intensity of the chief complaint is headed in the direction better, on we go. And we re-x-ray after 36 visits. I expect to see 25 to 50% measurable improvement on most patients that do that type of care. Everyone has 5 jobs and 10 kids around here, so I don't sell care. Okay, I don't be like, sign on the dotted line, get free steak knives right now. Act now. No. I need motivated patients that want to make improvements in their spine and understand that there's going to be work on the other end. Okay, so it's not about selling care in the clinic. In fact, I do my best to reduce the frequency in the clinic, especially when I could go ahead and set somebody up at home with the entire setup using a few blocks. So now it's on them to do it. I taper it down. Now they only need to come in to get unlocked or adjusted spinal alignment once every 2 weeks. So anyone that's doing this type of traction devices at home are getting adjusted every 2 weeks. Okay, I don't kick them out if they don't, but if they come back and they complain of pain, I make sure they understand they're not following the care plan. This is a lumbar ScoliRoll. Do you think this looks like it's fun to lay on your side? Okay, so it's not completely on your side because remember there's rotation. So you're kind of leaned back. This is for the low back, and it's a little bit more going for it because you have to deal with the ribs. This one here is for the ribs. It's a little kinder and gentler. These are tough to use, but they are effective, especially if they're younger, bendier people. It's nothing compared to what this can do. because this does elongation, derotates you, and pulls you midline all at the same time. This is more isolated to just very specific areas. So that's the traction. The exercise, let's say again, we have that reduced curve or reverse curve. The exercise is pretty simple. That's it. It's really not much more than that. I'm just trying to warm up the neck, warm up the spinal ligaments to get the patient prepared for the traction. That's it. That's all it does. So 100 pulls on this, lay on that from 7 to 20 minutes. 20 minutes is the max, setting a timer, and rinse and repeat. That's it. Ligamentous creep. So the way ligamentous creep works is we put a continuous stretch on a spinal ligament for, let's say, 12 minutes. Let's say that's a really good number, 12 minutes. All right, so you start here, you go here at 12 minutes. This is where you are with the amount of stretchiness, and like you've stretched the ligaments, you're here. Now over the next 48 hours, you'll slowly recover from that. If you do absolutely nothing, at 48 hours, you'll be back exactly to where you were before you did the traction. So the key is to do it every 24 hours so you never fully recover. That's how we make changes. So if someone is doing this kind of stuff 2 days a week, 3 days a week, they're not going to see the changes. It needs to be done a minimum 5 days a week or more. And again, has to be done in the clinic first to make sure people aren't being hurt. And you can't buy this stuff on, maybe if you can find it on eBay, they resell it, but they don't sell this to anybody. You have to be a doctor, a chiropractor to really sell these. And insurance does cover some of them, believe it or not, the neck ones. So exercise adjustment and traction, symptoms are generally gone in 2, 3, 4 weeks. So now I have to find the motivation for the patients to continue. And the motivation is the reminder that, do you remember the pain syndrome you had? Do you remember? We're looking for a change, a structural change, not just, oh, I'm feeling better. You know, even the oswestries where you're filling stuff out. Oh, objectively, you're doing much better. But I want to see the change on x-ray. I want to see what we call red line, green line. So red line, when I do the x-rays, I'm measuring the patient's distortion in millimeters and degrees, highly precise. So I'll put the red line on where they are, and then the green line will show where they should be. So there are millimeters and degrees of measurement that we're comparing to. And any x-rays I take later, I do a comparative analysis. And so I have software to do that. And so there's a goal in mind. There's a destination. And once we hit that destination, then it's a question of maintenance. Okay. All right, y'all sat long. I'll stand up, everybody, for 1 second. Okay. So, all right. So one of the things, I know not everyone here wears high heels, obviously, okay? But one of the things I talk about with high heels, it kind of clicks with people and they understand posture a little bit better. All right, so everybody go up if you can, it's safe to do so. Everyone go up on your toes a little bit. All right, so go back down on your heels. Now slowly come up, slower this time. Do you feel yourself kind of come forward when that happens? But we very quickly, our body's incredible. We right ourselves, we come straight back up. And this proprioception, there's a balance, and it's that it's amazing, right? Let's say for a second, everyone in here has an increased curve in their low back. If you go up on your heels and then you right yourself like this, what do you think happens to this curve in your low back? Does it increase? Right. Let's say you have back pain and you're wearing heels to work every day, and you have an increased curve in your low back. Would you be open to the idea that perhaps you shouldn't wear high heels? I try not to get to a woman in their shoes, but it seems like at a certain age, they're just like, don't care anymore. But I get resistance. All right, so while we're standing, Scoliosis check sheet, think ChatGPT, but then I did send it to a desktop order, so it's actually pretty nice. This is called Adams forward bending test. So everybody pair up with just someone else, if you can. Someone's gonna be a doctor, someone's gonna be the patient. Now, okay, you might need just a little bit of space because we're just gonna be bending forward a little bit, but don't bend forward if it's not safe for you to bend forward, okay? I don't want anyone falling on their face, please. So the whole idea with this is we're looking for rib humps or asymmetries. What I'm wearing is probably difficult to see. Looking to see when you bend over if the ribs are higher on one side or the other. See if you can do that with your partner. And bending over slowly, hair will be in the way, but easy does it. Don't. Okay. Nah, no, no. Hers is a little increase here, but now you're pretty good flexibility though. It's a little right here. There you go. All right, a little bit right there. Come on up. Okay. All right. You're oh, you did yours? Okay. All right. Were you guys able to see anything at all? A little bit. It's subtle, but it's there. And in young people, it's very obvious. Okay. And it could also, you could also actually see it in the low back when it's like an S. It'll be prominent in the low, but it'll always show in the rib. Okay. You can also do this just standing. All right. So if you see somebody in their one shoulder blade is very flared or prominent, and the other one, or I just see this. I just see this a lot. I can't unsee it. Like I mean, I'm like afflicted. I can't. I see everybody. So the other thing, which I think is worth noting, and I kind of see it here, is when people come forward like that, and it's sort of a pretty sharp, that can be indicative of a kyphosis, a hyperkyphosis. A kyphosis in the mid back is normal. A hyperkyphosis is not. So, and there are various things. Okay, cool. All right, you guys can sit down. I just wanted y'all to see that. So, who feels pain when they sit for extended periods of time? Okay, isn't your back? Back, everybody? Have you all seen what your back looks like on X-ray? Anybody? You have? What does it look like? Oh, okay. So I'm never surprised when I have to X-ray everybody. I'm never surprised, and I've been doing X-ray a very, very long time. I just couldn't imagine practicing that without it. To see is to know, not to see is to guess. I don't guess when it comes to stuff like this. Um, have you done anything to try to prop yourself up to take pressure off your low back while you're seated? Has intuitively, no one's done that? Yeah, I have to also as well. In fact, I think I feel it the most when I sit on an airplane. I mean, maybe being a little person, you sit in the chair and it's got that little thing just like this, and you're like, right? So if I get something and prop myself up here and then put something here, I'm much happier. I don't care if it's first class or not. Like it does not comfortable, right? So molding our environment to fit us is vitally important. Too often we are molding to our environment slowly over time, and that's where these pain syndromes start to pop up. The simplest thing to do is prop yourself up from the bottom of your rib cage, from the top of your low back, and just have that push forward to bring you up. The reason why I say that is some people that have too much curve in their low back, and if you don't know for sure, you might be putting those, you ever see the back supports that just come here and they're just here? They're not the full spine. So you might be actually pushing, you might be increasing a curve somewhere where you shouldn't be. So molding your environment to fit you is really important, but if you don't know what your distortions are, that can be a little challenging. Let's talk about sleeping posture. Who sleeps with more than one pillow under their neck? Is it comfortable? No? Yes? Who spent more than $100 on a pillow? All right, yeah, right. Are you happy with it? You don't know yet. Yes. Okay, cool. For me, and what I tell my patients is sleeping on your back is ideal. But if you have too much curve in your low back, that butt sinking down and jamming these facet joints together in your low back can become a problem because your butt's falling and your low back is pinching, if you will, while you sleep. So having the right surface is important. But some people that can't sleep on their back, on their side would be pretty good as long as your shoulder can tolerate it. What I don't want you to do is be sleeping like this. I also don't want you sleeping like that. I also don't want you sleeping on your side, but also on your stomach. And you all know what I mean, right? So neutral. But I was talking with them before. It's really difficult to maintain a certain posture while you're unconscious, right? But you just reset yourself. In particular, if we're on your side, I highly recommend, if you really are one of those people like, God, I keep finding myself on my stomach, I keep going this way, full body pillow right next to you to keep you from rolling fully. And then over time, you just start to develop that, where you stay more on your side instead of collapsing onto your stomach. Sleeping on your stomach is terrible because turn your head this way, bring your arm up this way, like that, and like this. And then you have gravity pushing you into the mattress for 8 hours. I can sometimes sit my patients down and turn them left and right. And I'll be like, oh, you sleep with your head to the left. How did you know? Yeah, well, you can't turn your head right. So, you know, it matters. Who here has a standing desk? All right, where'd you get it? Lander or like one of those kind of things? Or is it set or is it like one of these that goes up and down? Yeah, me too. The best. I would never trade it in for anything. Highly recommended. I mean, one, I'm a hyper child, so I like to keep moving. But this right here is much more dynamic than sitting on our ass and collapsing into this. So we're much more elongated, upright. It's just better to be upright and moving around. Also helps with steps in the day. Should people sit and rest? Of course. All right. But I'd much rather see people, if you're engrossed, engaged on a computer standing. Even I catch myself too, especially if I'm like doing x-ray analysis. I'm like, here, start like this. Like, what's that? Like, and then I'm like, someone comes over, talking to me, I'm doing like this. I'm like, ooh. You know, so we lose our awareness. It's just human nature to be sucked into whatever we're doing. But if we plan to support ourselves in a successful way, it can kind of catch us. So having a standing desk is really, really good. Okay, who here feels like when they're standing, they're like more on one side or the other, or they're always doing this, they're always doing that. They're like constantly, they can't just be like in neutral, right? You all know what I'm talking about? So in chiropractic biophysics, we don't use heel lifts for short legs, okay? We measure what we call a functional short leg using something called an A to P Ferguson's X-ray. It's an X-ray at an angle to measure the base of the sacrum. This is the base of the sacrum here. It's right here, the base where the disc meets the sacrum right there. It should be parallel to the floor. Quite often it's down, what we call sacral insufficiency. And then where the femur head attaches to the hip is now lower as well. So now that leg is functionally acting as if it's shorter. Meanwhile, the legs are the same length. Okay, it's just where it attaches. So when we do a heel lift, it rotates the pelvis. When we do a full foot lift, it just brings you up, brings it up. I have a full foot lift. I'm not wearing it right now. I have no shoes on. She doesn't let me wear my shoes in it. So I would have a full foot lift right now, about 5 millimeters, to level off the sacral base that brings the spine more midline. So the feet are the first thing to hit the ground. So to completely ignore the feet is not a good idea. So in chiropractic biophysics, we compare the pelvis to the feet, the thorax to the pelvis, and the head to the thorax without getting too far into it. Some elements of recovery also we use in pain management as well. So how many people use cryotherapy after working out here or working with the trainer or anything? Ice. Anybody use ice at all? No one? A little bit? So I have some preferences personally, and one of them is to not use heat. Heat is one of the most misused modalities, period. And I just make it very simple to my patients, whether they listen or I don't know. Don't ever put anything in the microwave or plug it in the wall and put it on your spine. Please don't. It's being used incorrectly. Promise you it is. It's not a hydrocolloid pack. You're not going for physical therapy. It's being misused. Please stop. When you do that, and especially if you replace it with ice, I see improvements in pain. I've seen it a million times. It's to the point where almost like I'm asking to take like their favorite teddy bear away from them. Sometimes, are you kidding me? I lay on for 45 minutes a day. Oh, every night I fall asleep on for 2 hours. I'm like, no, stop. You're hurting yourself. What's happening is when people are let's say you lay down every night, you can't fall asleep without your heating pad. I have to it's plugged in the wall. You're laying on it. You fall asleep with it on. You have it on for hours. What's happening is it's increasing circulation to a damaged area, which can then the fluid cannot dissipate. There's congestion there. So it stays stiff afterwards. The only thing that makes it feel better, more heat. Round and round you go. So breaking that cycle of pain using cryotherapy or ice, keep it on for 20 minutes, it's very helpful. I particularly like the kinds, like this is an elastogel. It goes right on the skin. You can get these Amazon. I saw them for the same price as Amazon in my clinic. I have a couple of them at a time, just so people understand what it is. It goes right on the skin. It stays cold for like 20 minutes, so it's perfect. And there's a Ziploc bag in here. If you keep it in the Ziploc bag, you throw it in the freezer, it'll last years. If you just throw it in the freezer, it'll fall apart in a few months. The other thing I really love are freeze sleeves. You like those, Tiffany? I love these. These are great for ankles, knees, elbows. It goes right on the skin, but also compresses at the same time. So I'm a fan of these type of things. So whenever we're working to make changes in posture, there is going to be achiness and soreness that comes with it because we're looking to make changes. My job isn't to just get people out of pain. Yeah, I mean, it's part of what I do, but it's not the most important thing I do. So if people can deal with the achiness and some of the soreness that comes along with the posture correction using ice afterwards or other things, it's really, really helpful. The last thing, or one of the things I want to talk, I don't even know how much time I have, kind of lost track. Okay. Who here gets headaches? All right. Have you ever noticed that you have neck pain and headaches at the same time? Anybody notice that you get headaches and neck pain at the same time? Yeah, sometimes. Okay. A million things can cause headaches. Okay. One of the most common things is neck alignment, and particularly a lack of curve in the neck or reverse curve. So helping to restore this takes pressure off the upper part of the neck and helps with headaches in a way that is, I'm never surprised by at this point. It's just, they're connected. So if you're struggling with that and you haven't looked at the neck and related to headaches, I encourage you to do a little bit of a dive on your own on research, and you will see there's lots of research connected to two of those things. But you're just not going to hear those kind of things from your medical provider. It's not because they have anything really truly against us. Maybe they do. They just don't know. And especially when it comes to scoliosis, unfortunately, I do not believe that watching and waiting is a good strategy for scoliosis. And medical practitioners, a lot of them do. In 2016, the SOSORT guidelines were very clear as to the gold standard for scoliosis treatment in kids, adolescents, adults, seniors. It is a combination of physiotherapeutic scoliosis-specific exercises. Has anybody here heard of Schroth PT before for scoliosis? It's out of Germany. It's sort of like a Kleenex of tissues, right? So it's like it has the name. Everything is always Schroth, even if it isn't Schroth. But anyway, so physical therapy combined with a 3D overcorrection brace is the gold standard for scoliosis non-surgical management, period. And most medical practitioners have no idea about this. Some orthopedic spinal specialists that are members of SOSORT, they get it. They understand. They're part of it. But the vast majority of neurosurgeons, orthopedic spinal specialists, even regular physical therapists don't know this. And regular physical therapists are not trained in scoliosis the same way chiropractors aren't trained in scoliosis. We have to go after post-grad to gain this knowledge and to gain this practical experience. I've kind of a little bit went off the rails a little bit. One thing I do want to mention before I open it up for questions is that, to me, when it comes to performance and exercise, mobility training at the beginning is so crucial to prevent injury. And Tiffany's really great with this. I mean, she has all the toys, right? So she has all the mobility stuff. And the three things that I always tell my patients is, just a regular foam roller, 5-inch massage ball, and a regular massage ball about the size of a lacrosse ball. It doesn't have to be as hard as a lacrosse ball. If you have these three things, I can show you about 100 ways to unlock your body or more. So it's prior to exercise. That's why they do that here, rolling on the foam rollers, using the massage balls, unlocking the body to prepare it for exercise. That's one of the things that really resonates with me. So I'm always encouraging my patients to do that because there's really only 4 types of pain that I treat in my clinic. It's soft tissue, joint, disc, and nerve. So even if the driver is a herniated disc or a nerve impingement that's then creating joint pain and muscle spasms, which is pain, there's like the genesis of it, treating the muscle pain and unlocking the joints is still going to be a part of it. And this isn't something that you would do. The mobility training isn't something you do here and there. It's a part of a regular wellness and exercise routine. And I encourage all my patients to own it. So you don't have to listen to anybody teaching you to do it. You should know how to do this. You should be able to put in your AirPods, spend 10 to 15 minutes on one side of your body, 10 to 15 minutes on the other side of your body, and then get into your exercise. That's really what I want to see with my patients. So I just want to open up to questions. You guys have any questions for me, please? Yes.
What do you think about yoga and stretching for managing posture
So I'm always running into the problems of certain things, okay? Because I get people that are flared up due to different things. I think yoga is great. I think it's great. I think it's not taught properly a lot of times. And I also think that people do not get the one-on-one correction that they need, and then the practice becomes a repetitive stress in itself. I'll give you an example. Let's go back to that increased curve in the low back here. Too much curve in the low back. So patient has too much curve in the low back. Everybody here that knows yoga, up dog, right? You're on your stomach, you're coming up, in essence, you're kind of, you're coming up like this here. The proper way to do it is to rotate around the femur heads and engage the core. That's it. That's not what I see. I see a bunch of people fulcring right into the low back, jamming their facets together. They're bending deep as far as they can. They're being in competition with themselves or the people left or right of the mat. So, and then they get the endorphins going, so maybe they don't feel it as much, or they get the heat going, so that really loosens the muscle and they overstretch it. Is it good? Yes. Is it misused? Yes. So it has to be done correctly, and people need to be honest with themselves of how they're feeling beginning, during and after. If you're like, oh, I love it, but I am a little achy afterwards, but it's okay, it's worth it. But it's joint pain that they're aching, so they're injuring themselves, but they're not aware of it. So that's the only thing I would caution people on. Aside from that, it's great. Yogis for 1,000 years can't be wrong. It just needs to be the appropriate treatment for the appropriate condition for the appropriate patient. And that type of exercise it can be pretty dynamic, but there's lots of really good instructors out there, and we have to be our own advocates. We have to walk up to the yoga instructor and be like, look, I have X, Y, and Z going on. Just keep an eye on me, making sure I'm, did this and that. But, okay, gotcha. Thanks for telling me. That's really helpful. CrossFit, please don't. That's the only thing I could say. There's certain types of exercise that are just a no, and that's one of them. And I think it's just fundamentally flawed philosophically, because I just see so many terrible injuries from it. I could never, ever, generally speaking, I cringe when a patient walks in and telling me they're doing it. Like, ugh. I like ScoliCare though. I like that one. You got to go, I wouldn't crush it. I like reformer Pilates first. And you do well with that, you really love it, you're advanced, go for ScoliCare. How about that? Yes. When a patient comes in with an acute problem, I generally see them 2 to 3 times a week for about 6 visits. During that time, again, I want to see the frequency, duration, intensity of the chief complaint headed in the direction of better. If it's not, they're generally going to find themselves in an MRI tube. And I can write those scripts without contrast, or an NCV or both. Because the MRI is the what, the structure that is seen, what the magnet can see. The NCV EMG is the how the nerves are firing, how the muscles are contracting. You put the what and the how together, you get a pretty vivid picture as to what's going on with the patient. Then it's just a question of applying least invasive things first, graduating to more invasive things over time. Active isolated stretches, some manual therapies, deep tissue laser, very gentle spinal manipulation, and if appropriate, traction. But these types of posture correction traction can't be done on a patient over 1 to 10. 10 is the worst pain imaginable, 1 virtually no pain. If you're over a 3, I'm not doing this type of traction on someone. I might be doing other forms of sort of palliative types of traction. I have some decompressive type of things for different parts of the body that are, you got to get it calmed down first before I can start molding them back, if you will. Yes. Can you talk more about the other exercises? Deadlifts. Picking up, and so my definition of a deadlift is different. Anything coming off the ground with your legs straight, to me, is a problem for many of my patients. They do not have the hip mobility or the flexibility or the structure in their low back to allow for that type of dynamic movement. You got to bend the legs. Some people say, well, dead weight is just going from a dead rest all the way up. It's like, well, if that's the case, then it just needs to be careful. But to me, the Bulgarian squat, no. Like, not this kind of stuff or this kind of, not with resistance, not with bands, not with 10-pound weights, not with 5-pound weights, with no weight. Like, please don't bend your knees, please. I just see so many people injure themselves that way. I mean, when they're young, I guess people can do it, but people generally don't have the structure and the flexibility in their hips and low back to allow for that kind of dynamic motion against weight. Well, does your back hurting afterwards, though? I mean, are you hurt? Are you pain? Okay, as long as you're feeling pretty good, then great. Then you have the, just be mindful, be mindful. Easy does it. You know, perfect form, low weights, you know, making sure your mobility is good. You shouldn't be hurting, you know, perfect form, low weights. That's it. You know, that's Tiffany's an expert in this stuff. She is truly an expert. And then also, when we're talking about collapsing deformities of the spine, there's absolutely no reason to ever put a bar on your shoulders. Like, I mean, if you want to do one of the stretching bars, that's fine, but nothing with weight on it. Like, there's no reason to just pick a different exercise. You know, there's just no need. And also, a lot of people using these weighted vests. No, it's not for you. You know, you can't even walk 3 miles without a vest on, and you're going to put a vest on now, and you're distorted, and you have osteoporosis. Like, please don't. You know, it's just, I understand it's like the greatest newest thing, but it's not, everything is right for every person. And please don't ignore pain that doesn't go away. You know, don't pop pills and be like, oh yeah, I'm okay. Yeah. Go ahead. You're next. Go ahead.
Is there a distinction? Spinal issues, back. Are there certain things around the back? I'm just thinking, like, oh, I'm getting out of these people, like, no, like, oh, I think I'm worried about it. That's like, that's great. How much that makes it back? Like, oh, every now and then it's first, but nothing common to exercise, feel something in the morning. I distinguish, is there a distinction?
I mean, it's a good question. I think it's a lot of that could be answered in your approach. I have a lot of tools in my toolbox, so I say lots can be done. Oh yeah, like, you know, don't start with the injections yet. You know, put that scalpel away. You know, there is hope, but it's my specialty. So you go to a regular ortho that's doing hips, knees, and whatever, and you go to just a regular PT, they're not going to have the same tools, so their outlook might not be the same. Almost never is something only muscular, just never, especially in an aging spine. At the very least, there's joint pain there. A lot of times it's joint and soft tissue. Everybody's a little bit different in how we degenerate over time. So if the discs are actively really fast and quickly degenerated, then that's, you know, then that's more of like, oh, wow, yeah, this is happening. It must be a genetic thing. You know, there are things that you can do, but there's not a lot to do. The vast majority of people, just generalized spinal manipulation combined with even just slightly addressing the posture, quickly they see reduced symptoms. So that means that the distortion of posture was part of it. When you're talking about spinal problems, I mean, I've seen you could have hemangiomas, you could have benign tumors in there, you could have an extra segment in your low back, you could have a segment that's, your body didn't know if it wanted to be a bone in your low back or part of the pelvis, so it did both. It's called the transitional segment. So there's all sorts of different presentations, so it's very much individualized. But for the most part, almost never is it just soft tissue, unless you're talking about a strain, a repeated strain. But the most common thing that I think that you're just like, there's not that much I can do about is the range of motion that's available to a degenerating spine after I've worked on, or someone like what we done. Like, you're like, okay, well, that's about as good as we're going to get you. But just looking at it without trying that, I'm really not sure. A lot of times the rigidity and the stiffness, that comes with age. But I go to Laura every 3 o'clock on Friday. Sorry, you can't have that time. All right, it's mine. So I go for massage every week. I mean, I need it. So that I'm taking care of that. So the muscle, the fascia, maybe some adhesion. So I firmly believe, and I've witnessed it in myself, there is a cumulative effect on these type of treatments when it's done. Soft tissue work, massage, deep tissue massage, acupuncture, some chiropractic care in certain instances. There is a cumulative thing over time. And especially with the posture care, it's a little difficult with patients that have been through the ringer and they've been sold in every which way, shape, or form, and none of it has gotten them where they want to be. So trying to be like, I just need you to be patient for a couple of months. It's like, yeah, my patience is gone. So it's hard. But like I said, if I see some daylight within the first 6 visits or so, that's when I'm like, okay, cool, let's do this thing. And then off we go. So I hope that answers your question. I really wish I could give you a little bit more specific, but there's just so many presentations, and some are be like, oh, well, this is acute, or this is because, you know, you landed on your back because you were horse riding. Other one is because just genetics. So like I get somebody that like let's say it was a football player, a lineman, their back is almost always flat because they're always on their back. And so there are certain things that people don't even realize because they don't feel it because they're young. And then as they get older, that's when they start to feel it, because the degenerative process, a traumatized spine will degenerate faster than a non-traumatized spine. And not just with landing on it, like whiplash. So any part of your spine that's had a trauma to it or a whiplash injury, that area is much more susceptible to arthritic changes and degeneration over time.
What do you think of the best?
Yeah, rest is helpful, but most of the time people aren't moving enough, and the body has a self-correcting mechanism. So if we kind of get moving, it can move, things can move around, and we can feel better, do better. Okay, but it's individualized. It's depends on the situation for the individual. The biggest myth is that if you go to a chiropractor, you have to go forever. That's the one, or that we're going to kill you. Well, I tell you this, my malpractice insurance is less than my car insurance. And I've been practicing for 30 years. It goes up every year, and it's still less than my car insurance. So we don't kill people. We leave that to the medical doctors. What's that? Stretches. You know what I really like? I like the castle flex. You ever see that? The thing where you like you wrap it around and you kind of pull it. You can do it, and you get the different parts of your glutes, and each part you can isolate the different parts of your hamstring. So I like being on my back with a strap or a rope, or I like the castle flex because it forces your, like it's like a thing that kind of hooks your entire foot. Feels really great. I love that. The other one is my favorites are hamstrings, glute, and then piriformis on your back, like the knee, bringing that one over. Those are my favorite for the low back, for sure. And then also what's really good, laying on your back with your feet flat and then have your knees go side to side like this, not the dynamic. Please don't. Please don't. Yeah. Oh, go ahead. Sorry.
Talked a lot about people who don't have pain. How do they know when they should?
When they look in the mirror and they're like, or they see photos from the side and they're like this, or they're like going to the tailor, be like, why is my cuff? You know what I mean? Like they look at objectively, or sometimes loved ones. You're like, Mom, you're looking like this or like that. So, and those patients are challenging because it's like, you feeling okay? You're doing okay? Are you gonna be okay when you're not feeling so great after I treat you at first? Because you're gonna be achiness, soreness, and a little bit of discomfort. You okay with that? Yeah, I'm okay with it. You know, so there's that conversation to have. Like, I felt great before I came to see you. No, you know, it's you know, but yeah, pain is the last thing to show and the first thing to go, typically. And if you're not hurting, but you have bad degenerative changes, amen. Thank God. But it can change quickly. Go ahead.
So this is kind of ironic because I have been diagnosed with it. However, I've been trying to find some answers. I invested in a Kraus set where it looks like it's designed for lumbar support and all the stuff that is nice and comfortable. And over time, I recognize this thing, but you know, that it forces me to flout and body a little bit.
Yeah, it's no good.
I tell myself I need to find just to get a regular chair. And I was actually bringing a chair today from my house, and my daughter asked, and I brought this, and I said, let me sit in it. This downstairs in the room, my house, and I never used it. And I came here and I sat up here, and I find this thing is very supporting my back. I was like, wait.
Yeah, because it's hitting your spine right where your mid back and your low back meet. It's propping you like this.
This year, I'm just kind of designed different. But almost like you have to find it right. Yeah, and it's just ironic that it's crazy. I'm sitting there.
Yeah, it's amazing that it's amazing that something as simple as sitting on the couch can be a repetitive stress if you're not sitting appropriately for you. Yeah, like I'm the same way. If I kind of collapse into, I can't sit like that. I will sit on the edge of the couch, like sitting up straight and be like, oh, wow, you sit so tall. It's like, well, if I sit any other way, I'm in pain. So I can't.
And put those pillow back there. It doesn't really give me pain per se, but I recognize it's not helping my situation.
Yeah, it's not helping. We want to mold our environment to fit us. If we start molding to our environment, it's never good. So and we have the ability to do it. We just have to do it and then be consistent about it. So it's, yeah. Anybody? What's that? I had to see his x-rays. Let me talk about it for 1 second. Not everyone's a candidate for this. I've said no quite a few times. And recently, for some reason, I've gotten a few people that are just too far gone, or just I know they won't tolerate it. Also, they're expensive. The braces are $5,000. They're about to go up to $5,500 next month because, well, they've raised the price on me, and it's not covered by insurance. So that's a problem. It's considered investigational experimental. So if it was covered by regular insurance, I would have a line out the door, but it's not. When I press the button to order one of these, today it cost me $2,500. August 1st is going to cost me $3,000. Cost me. So it's like in the braces that are covered by insurance, they only reimburse $1,200, $1,400. So it's like the math doesn't work, the code doesn't work. It's out of pocket, but it's much better than surgery. I'll tell you that. Exactly. And there's no guarantees. I've seen a lot of failed back surgeries, a lot. Last house on the block, keep it there. Try everything else first. But I know some really good surgeons if people do need it. Okay, so, and I get patients to where they need to be. And I'm a big proponent of individuals deciding on their own without pressure what's best for them. Okay, and so, and I live that. Everyone gets my mobile number. I asked Tiffany to email you guys a few links, but it'll have my personal email and my personal mobile number on it. You need me for anything, call or text me. If you need referrals to other type of providers, I know a lot of people, a lot of really good practitioners. So that is my offer to you. Also, anyone that wants to come in, I'll do free initial evaluation, consultation, and x-rays, and go over the posture report with you so you can see your own posture on x-ray. What's that? I could probably get you in this week sometime if you want. I'll make it happen. I live a block away from my clinic. I live at the corner of Bethesda and Woodmont. My clinic's on the Woodmont and Elm. If you know where Bella Salon is, I'm above that. I have the 3rd floor above that. There's Dig on the 1st floor, Bella, and then me. So, oh, you're very welcome. Look, going over this kind of stuff could be a little bit like drinking out of a fire hose. So please, by all means, send me questions, okay? Thanks so much.
Before you guys leave, I just want to first say thank you again for Dr. Van Kraus for coming and speak with you guys today. He's been a referral partner for a while. Trust him with our clients. We've also, like you said, we refer back and forth. I'm literally running out of here because I'm doing a fascial course. So all this posture stuff we're looking at and helping to work with to kind of make sure that you guys have a holistic care. That's really important for us here. So thank you for being amazing and for time out of your day. One other thing, we also, for those, most of you are clients, for those who are not clients, we do have a performance start plan where you can come in, get an assessment, try our facility for a week, and also try out semi-private class. We do individual training and semi-private. So we're looking at how you're moving so we can make those changes for you when you are training. Another thing, this is put on part of our foundation. And so we have next month, August 2nd, put on your calendar, scan in, talk about that other stage. Everyone heard about the cortisone socks, about PRP, regenerative medicine. We have Dr. Ashke Garg and Dr.
I refer to him a lot.
Oh yeah, so
he's a physiatrist. I was telling you about.
Yep, so he's coming.
It's great.
Here, talking about other things there. So we're trying to give you an opportunity to learn when there's an PRP, when it should work and not work, and how to use it as a complete.
Without ego, guys, I consider myself an advanced practitioner, just a fact, okay? She is an advanced practitioner in what she does. I'm very impressed with what she does and have been for a very long time. So I'm glad you all are here. If you need to know that you're going to be safe training and expanding your strength and mobility, She can be trusted, and you're not gonna find anyone else better around here, period.